If you, or maybe someone you care about, is currently navigating the frankly exhausting maze of menopause treatments right now, you've probably heard the term body-identical HRT thrown around.
Oh, absolutely. It's everywhere.
Right. It's pitched basically everywhere as this new gold standard. But, whenever a medical term suddenly becomes this massive buzzword, it forces a really important question. Is it just clever marketing to sell a newer, shinier product, or is there, hard peer-reviewed science actually backing this up?
Yeah, and that tension between marketing hype and biological reality is exactly what we're looking at today. I mean, we're dealing with an area of medicine, specifically women's health and menopause, that has historically been plagued by wildly changing guidelines.
Oh, the whiplash has been real.
Exactly. Conflicting media headlines and, frankly, just a lot of unnecessary fear.
So our mission for this deep dive is to cut right through all that noise. We've got a massive stack of sources on the table today. We are looking at the latest clinical guidelines from the British Menopause Society, massive cohort studies like the French E3N study, the Esther trial, and some really comprehensive medical reviews.
It's a lot of data.
It is, and we're using all of it to answer one very specific question. Is body-identical progesterone, which is often called micronised progesterone, actually safer and better tolerated than the older lab-made synthetic progestins that doctors have been prescribing for decades?
And, to really understand the stakes here, we have to look at the baseline reality of menopause first. The data shows that menopausal symptoms affect between 70 and 80% of all women.
Wow, that's almost everyone.
Yeah, and we aren't just talking about a brief, mildly annoying transitional phase either. A quarter of women describe their symptoms as severely debilitating. And the average duration of these symptoms is 7 years.
7 years of dealing with that.
Right. And for up to a third of women, they persist even longer. So 50% report that these symptoms actively disrupt their home and work lives. It is a massive systemic quality of life issue.
Right, and the absolute gold standard for treating those symptoms is estrogen. I mean, estrogen is the biological powerhouse that stops the hot flushes, it protects the bone density from osteoporosis, and clears up that really profound brain fog.
It's incredibly effective.
But there is a major catch, right? If you still have your uterus, an intact womb, you can't just take estrogen on its own.
No, you absolutely cannot. Because estrogen fundamentally promotes cellular growth. It causes the lining of the womb, the endometrium, to thicken.
Okay.
And if you just let that growth go unchecked month after month, it can lead to a condition called endometrial hyperplasia. That involves abnormal cell changes and is a direct precursor to endometrial cancer.
Which obviously we want to avoid.
Exactly. So to protect the womb lining, anyone taking estrogen who still has their uterus has to take progesterone alongside it. Progesterone acts as the necessary biological brakes. It stops that unchecked cell division and keeps the lining thin and healthy.
Okay, let's unpack this. Because the specific type of progesterone you take to pump those biological brakes, well, it seems to matter immensely.
Oh, it makes all the difference in the world.
Yeah, so before we get into the long-term safety data, we need to understand exactly what these two different substances are doing inside the body.
Right, and what's fascinating here is the sheer pharmacological difference between the options. When we use the term progesterone, just that word alone, we're referring to the natural hormone.
The one our bodies actually make.
Exactly. And in modern medicine, this is often derived from a plant substance called diasgenin, which is extracted from Mexican yam roots or soy. From a chemical standpoint, it's structurally identical to the hormone produced naturally by the human ovary.
Hence the term body-identical.
Exactly. On the other hand, when we say progestins or progestogens, we're talking about synthetic lab-created versions.
Okay.
These include older medications like northisterone or medroxyprogesterone acetate, which is often abbreviated as MPA in the literature.
Right, so think of hormone receptors in your body like locks on a series of doors down a really long hallway.
I like this analogy.
Thanks. So body-identical progesterone is the perfectly cut original key. You slide it into the lock, it smoothly opens the one specific door it's designed for, the progesterone receptor, and it does its job protecting the womb. But synthetic progestins, on the other hand, are like a skeleton key. Yes, they manage to force open the door you want them to open, but because their chemical shape is slightly different, they accidentally jiggle the locks on a bunch of other doors in the hallway, pushing them open too.
And those other doors are actually other vital steroid receptors in your body. It's a great way to visualize it. The synthetic progestins have this really messy habit of interacting with glucocorticoid, androgen, and mineralocorticoid receptors.
Which sounds like a recipe for chaos.
It Kind of is. Micronized progesterone has a highly selective effect, so it leaves those other complex systems completely alone. But when you activate an androgen or mineralocorticoid receptor unintentionally with a synthetic, you're triggering a whole cascade of metabolic impacts and side effects that your body never asked for.
Okay, so if the body-identical version is the perfect key, and it just comes from yams and soy, why did science ever bother inventing the synthetic skeleton keys in the first place?
That is the million-dollar question.
I mean, it seems completely counterintuitive to go into a lab and create something that causes collateral damage when nature already provided the exact blueprint.
Well, it all came down to a massive historical hurdle in pharmacology, specifically regarding delivery. Natural progesterone has terrible oral bioavailability.
Meaning you can't just swallow it as a pill.
Right. If you just take raw natural progesterone in a standard pill, less than 5% of it actually makes it into your systemic bloodstream. The rest is destroyed by what we call the first pass effect.
Okay, what's that?
So your liver acts as this incredibly aggressive biological bouncer. It sees this oral natural progesterone coming from the digestive tract, metabolizes it almost instantly, and filters it right out of your system before it can even do its job in the uterus.
Ah, I see. Which means you'd have to take dangerously high doses just to get a tiny bit past the bouncer.
Exactly. So for a long time, the synthetic progestins were a necessary workaround. They were chemically altered, essentially given molecular armor plating, to survive the liver's filtration system and stay active in the bloodstream.
Oh, that makes sense.
Yeah, and it wasn't until a process called micronizing was developed that things finally changed. Micronizing physically breaks the natural progesterone down into incredibly microscopic particles, usually suspended in oil.
And that gets it past the liver.
Well, it dramatically improves its absorption through the gut wall. And once that technology existed, oral body-identical progesterone finally became a viable, reliable option.
So the synthetics were basically a 20th century technological bridge until we figured out how to sneak the real thing past the liver.
That's a perfect way to put it.
But now that we know these synthetic skeleton keys interact with unintended receptors, we have to look at what that collateral damage actually is. Because it doesn't stop at minor side effects, right?
No, unfortunately not.
If they're accidentally unlocking random doors, what is happening inside those reams? Which brings us to the single biggest fear surrounding hormone replacement therapy, and that's breast cancer.
Yeah, the fear of breast cancer has completely defined the public perception of HRT for over 2 decades now.
Totally.
But the sources we're analyzing today paint a highly specific, nuanced picture of where that risk actually originates. Let's look at the French E3N cohort study. This was a massive, incredibly robust undertaking. They followed over 80,000 postmenopausal women for an average of over 8 years.
Wait, 80,000? That is a staggering sample size. You really can't just wave that data away.
You really can't. It's foundational. And the findings were stark. For women who took estrogen combined with a natural micronized progesterone, the relative risk of invasive breast cancer was 1.00.
Okay, let's pause on that real quick. A relative risk of 1.00 means there was zero increased risk compared to women who never took HRT at all.
Oh, precisely. No statistical difference from non-users whatsoever.
Wow.
However, for women taking estrogen combined with the older synthetic progestins, the relative risk jumped to 1.69.
Jeez. That is a huge jump.
It is a highly significant increase. The study clearly demonstrated that the association of combined HRT with breast cancer risk varied entirely according to the type of progestogen used.
See, here's where it gets really interesting. Because for years, women have been terrified of estrogen. The whole cultural narrative was that estrogen causes cancer.
Yes, exactly.
But this data strongly suggests that the increased breast cancer risk, historically associated with combined HRT, was being driven specifically by the synthetic armor plating on the progestins used to protect the womb. It wasn't the estrogen driving the risk, it was the synthetic skeleton key.
It's a huge paradigm shift. And we have to view this in the context of the broader medical literature, too. There's a widely cited meta-analysis called the CGH-FBC study.
Right, the big one.
Yeah, it's a major paper that often informs international clinical guidelines. And it did show a duration-dependent increase in breast cancer risk with combined hormone therapy.
Which sounds scary.
It does. But what often gets lost in the terrifying headlines is a crucial nuance. The authors of that meta-analysis explicitly stated they lacked enough data on women using micronized progesterone to draw any conclusions about it.
Are you serious?
Yes. The vast majority of the scary data showing elevated risk was based on those older synthetic formulations.
So when someone throws out a blanket statement like HRT causes breast cancer, they're ignoring the actual chemical reality of what's being prescribed today.
Yeah.
I mean, the body-identical key behaves entirely differently than the synthetic skeleton key.
Exactly. And the difference in how those receptors are activated doesn't just affect breast tissue either. It radically changes how the blood and the entire cardiovascular system behave.
That feels like the perfect transition into the blood clot data. Venous thromboembolism, or VTE. This is another major life-threatening concern that comes up the second you type HRT side effects into a search engine.
It's a very common fear.
Yeah, so if the synthetics are causing abnormal cell behavior in breast tissue, what are they doing when they're circulating through our veins?
To understand the VTE risk, we look to the French Ester case control study. They examined postmenopausal women to see how different HRT regimens impacted the formation of dangerous blood clots.
Okay, what did they find?
They found that transdermal estradiol, meaning estrogen absorbed through the skin via a patch, gel, or spray.
Which bypasses that liver bouncer we talked about.
Exactly, it bypasses the liver entirely. When that was combined with micronised progesterone, it was not associated with an increased VTE risk compared to non-users. The relative risk was essentially neutral.
But I'm guessing the synthetic options tell a very different story here.
In stark contrast, yes, the use of the older lab-made synthetics increased the risk of VTE by fourfold.
Fourfold? That's insane.
A fourfold increase in the risk of dangerous blood clots compared to non-users. Certain synthetic progestins, particularly MPA, actively make the blood thicker and stickier by enhancing the production of clotting factors.
Just by unlocking those wrong doors again.
Right, and if we connect this to the bigger picture, it all comes back to those unintended receptor activations. Synthetics like MPA have been shown in crossover studies to significantly increase something called serum HS-CRP.
Which is what exactly?
That's a well-known biomarker for systemic inflammation. When you have high systemic inflammation, it damages the lining of your blood vessels. And that is heavily implicated in atherosclerosis, which is the building up of plaques in your arteries and ultimately heart disease.
That is terrifying. What about the natural stuff?
Micronized progesterone, on the other hand, has a neutral or even potentially protective effect on the hemostatic system. It just doesn't trigger that dangerous inflammatory cascade.
Okay, but let me ask you this. If oral synthetics were problematic because they basically bathe the whole cardiovascular system in inflammation and clotting factors, I have to assume the Mirena coil works differently, right? Because the clinical guidelines still recommend it, even though it uses a synthetic progestogen called levonorgestrel.
That's a really great point. The delivery method changes the entire risk profile here. The Mirena coil is an intraborgan device. It's inserted directly into the uterus, where it delivers a very small, continuous dose of the hormone locally, right to the exact endometrial tissue that needs protection.
Oh, I see. So it doesn't go everywhere.
Right. Systemic absorption, meaning the amount of the synthetic drug that actually makes it out of the uterus and into your bloodstream to affect your breasts or your vascular system, is absolutely minimal.
That makes total sense.
Yeah, because of this localized delivery, it provides excellent, highly reliable protection against uterine cancer without appearing to increase the systemic risk of blood clots or inflammation.
So relating this directly back to the choices you might be making with your doctor, if your ultimate goal is to protect your heart, avoid systemic inflammation, and bypass the risk of blood clots, the clinical data heavily supports pairing a transdermal estrogen patch or gel with either oral body-identical progesterone or a localized Mirena coil. You're basically trying to keep the systemic disruption as low as humanly possible.
That is the clear consensus emerging from the modern data.
Yeah.
We want the benefits of the hormones without the vascular collateral damage.
Okay, so we've covered the heavy hitters now: breast cancer, blood clots, heart disease, the long-term, life-threatening stuff. But I want to bring this down to, like, Tuesday afternoon. Let's talk about the day-to-day reality of living with these medications.
Let's do it.
Because the data shows something really surprising. The main reason women actually quit HRT usually isn't a generalized fear of getting a disease 10 years down the line.
No, it's not.
They quit because the side effects of the medication make them feel absolutely miserable right now.
Tolerability is the massive hidden factor in hormone therapy. And again, your lock and key analogy explains perfectly why this happens. Remember how we said synthetic progestins accidentally activate androgen receptors?
Right.
Well, androgens are typically male-dominant hormones like testosterone. When a synthetic progestin mimics an androgen surge in a woman's body, it signals the sebaceous glands to overproduce oil, disrupting the skin and mood regulation. This triggers a whole host of side effects that mimic severe premenstrual syndrome.
Right, so we're talking about aggressive adult acne, greasy skin, severe bloating, fluid retention, and wild mood swings or depressive symptoms.
Exactly.
Imagine finally getting your horrific hot flushes under control with estrogen, only to be thrown into a state of continuous, synthetic, medically induced PMS. I mean, it's trading one nightmare for another.
It really is. It's a profound clinical challenge, and it's why adherence to older HRT regimens was often so poor. But this is where the newer body-identical formulations are showing massive quality of life improvements. Let's look at the data from the Replenish trial.
Okay, what was that one?
This was a phase 3, double-blind, randomized controlled trial looking at a medication called Bijuve. It's a single daily oral capsule that combines 1 milligram of body-identical estradiol with 100 milligrams of micronized progesterone.
Wait, so it's the estrogen and the progesterone combined into one convenient daily capsule.
Correct. It puts both the body-identical estrogen and progesterone into one oral dose. And over a 12-month period, the trial showed that this combination safely protected the endometrium and effectively eliminated moderate to severe hot flushes.
That's great.
It is, but the standout data point wasn't just about the symptoms it stopped. It was about the daily functions it actively improved. The trial demonstrated statistically significant, sustained improvements in sleep parameters.
Oh, wow. The sources point out that up to 3/4 of menopausal women suffer from severe sleep disorders, right?
Yes, it's incredibly common.
Insomnia, waking up drenched in night sweats, staring at the ceiling at 3 a.m., unable to get back to sleep. I mean, the cumulative fatigue from that alone destroys your work productivity, your relationships, and your mental health. Having a progesterone component that actually aids in sleep isn't just a minor perk, it's a massive daily victory.
It really is. And micronized progesterone has a known mild sedative effect. It actually interacts positively with GABA receptors in the brain, which help promote calmness and sleep.
Oh, that's why they say to take it at night.
Exactly. It's almost universally prescribed to be taken right before bed. And from a healthcare economic standpoint, it's really important to note that these modern body-identical formulations are cost comparable to the older therapies.
Really? I would have assumed they were way more expensive.
Not at all. The documentation shows a 28-day pack of this combined capsule costs the UK's National Health Service roughly £8.14, which is exactly the same price as older synthetic combinations.
So it's not a case where the safer, better tolerated medication is astronomically expensive and out of reach for the average person. It's literally price matched.
Exactly. But this raises an important question, though.
Okay.
If body-identical micronized progesterone is so chemically perfect and so cheap, why do some women still struggle immensely with it?
Well, let's stretch our analogy a bit. Even if you have the perfect original key, sometimes the lock itself is just sticky.
Right.
The medical reviews highlight a very real phenomenon called progesterone intolerance. Even with the perfect yam-derived key, which is often prescribed under the brand name Utrogestin, some women's receptors are simply hypersensitive to the hormone.
And symptoms of progesterone sensitivity can be quite severe. Women report profound brain fog, mental sluggishness, feeling physically heavy, intense fatigue, and a deep, flat, low mood.
That sounds awful.
It can literally feel like waking up with a chemical hangover every single day.
So what does this all mean? It means that if you're reacting badly to your HRT, you aren't crazy, and it's not all in your head. Your body is communicating a chemical incompatibility. No hormone, no matter how natural or body-identical it is perfectly tolerated by 100% of the human population.
That's right.
If you're feeling sluggish and depressed on micronized progesterone, you might just need to change the type of progestogen, or adjust the dose, or change the delivery method to something localized like the Mirena coil, or even switch to a vaginal delivery of the progesterone to completely bypass the digestive system and the liver.
And the clinical guidelines explicitly state that if a patient is experiencing progestogenic side effects, there's almost always at least one alternative regimen that will be tolerated. The ultimate goal of modern menopause treatment is highly individualized care, not forcing a woman to adhere to a rigid chemical regimen that destroys her daily well-being.
There's also one vital, highly practical detail from the sources regarding Utrogestin specifically that you need to know, especially if you have specific dietary or ethical restrictions.
Right. The outer capsule of oral Utrogestin contains both soy lecithin and bovine gelatin.
Meaning, if you have a severe soy allergy, Taking this pill is an immediate non-starter. And
Hmm.
because it utilizes bovine gelatin, which is derived from cows, it's not suitable for vegans, vegetarians, or individuals from certain religious groups who strictly avoid beef products.
It's such a crucial point.
It seems like a minor formulation detail, but it has a massive impact on who can actually ingest the specific gold standard medication.
It perfectly highlights why prescribing can never be a lazy, one-size-fits-all approach. A doctor has to treat the complex human patient sitting in front of them, taking into account their unique biology, their lifestyle, their allergies, and their ethics.
Absolutely. Well, let's bring all of this together. We started with a stack of complex data in a simple question. Is body-identical progesterone actually superior to the synthetics of the past, or is it just hype?
And the sources paint a surprisingly definitive picture.
Yeah, they really do. When you look at the massive French E3N cohort, the ESTER trial, and the latest clinical guidelines, micronized progesterone offers a vastly superior safety profile. It doesn't carry the significantly elevated breast cancer risks associated with older synthetics. And when paired with transdermal estrogen, it doesn't increase the risk of dangerous blood clots or trigger the inflammatory cascades that lead to heart disease.
And beyond the critical long-term safety, the data shows it's generally much better tolerated on a daily basis. It avoids the miserable PMS-like androgenic side effects of the synthetics, and its mild sedative properties actively help combat menopausal sleep disorders. By almost every pharmacological metric, it is a clear, significant upgrade.
But the data also demands that we leave you with a final lingering thought. We've spent the last 20-plus years watching an entire generation of women avoid hormone replacement therapy completely. They suffered through the hot flushes, the silent bone loss, the brain fog, and the chronic sleep deprivation out of a generalized headline-driven fear of hormones.
Based on the rigorous data we've unpacked today, it forces a really difficult, almost philosophical question about modern medicine.
Yeah.
How much of that deep-seated fear and how much of that unnecessary suffering over the last 2 decades was caused not by the fundamental idea of replacing declining estrogen?
But simply because 20th century science was stubbornly using the wrong synthetic skeleton keys to try and do the job?
Exactly. If we had just been using the right key for the right door from the very beginning, how completely different would the global conversation around women's health be today?
That is a really powerful thought to carry with you. Something to seriously think about the next time you or someone you love sits down with a doctor to discuss their options.